Couple things I want to mention though. So GAE and CLI, I don't treat those patients, especially if they truly have CLI. I look at the geniculars as the bypass circuit for the leg, if you will. What do you guys both do there?
Ditto. Same. I mean, I think at the end of the day, this whole hour is about GAE, but this is still unproven territory. This is not the standard of care. This is not in a single guideline by any society. And so we have to be mindful and careful of that. The last thing you need to do is hurt people. And especially maybe not upfront, but like if you jail their collaterals and they need those in a year or two, if they have CLI, that's going to be a big problem.
Yeah, great point. And then to your point about femoral, I mean, even if I'm going retrograde, I don't feel the need to stick the CFA. I will very commonly stick SFA depending on where the bifurcation is. I don't think twice about it, especially if the groin is a little bit hostile. And you obviously do the same in the integrated approach. And I think this notion that we have to be above the bifurcation all the time is really a fallacy. And it sounds like you both agree there as well.
Keep in mind, Cubby, that the stuff that Oz is using and I'm using is downsized, right?
Yeah, sure.
And I think that's partly why. If you were gonna, I don't know if I'd put an 8-9 French sheath in the SFA. That might be a little bit dicey, right? So
agreed.
But a 4 French glide cath, I don't see an issue.
Well, but like a true 5 or 6 French sheath, even a retrograde SFA approach, I'll still close that, and I don't really have a problem with that, right? And then Oz, to your point about the OBLs, I think that's a little bit of a tricky one for us, right? I mean, time, recovery, patient throughput is very important in the OBL setting. So I understand the interest in going that direction, but to your point, to Sid's point, actually doing the embolization can be much more challenging. So I know we talked about both of you don't close sheaths versus sheathless. Catheter selection, Sid, microcatheter, microwire choices for both of you?
So if I'm doing an ipsilateral approach, I do a 4 French glide slender sheath, 4 French glide cath, and a 1.7 French microcatheter. Right now, what I'm using is a Echelon 10. I'll be honest, I don't know if it makes a big difference which brand you use. This is just what we kind of started with, but I would advocate for smaller microcatheters, right? We started with 2.4 French. I felt like it was too big.
Oz, 1.7 versus 2. What do you think?
I use 2, and I know probably this will get into our conversations about embolic, but I think going to a temporary embolic, I think it's probably well recognized that I use the Padia joint for a lot of my cases, where I don't think you actually need to go distal anymore. You actually just kind of go proximal or mid and basically go to stasis. So I kind of follow Sid's advice that for me, actually doesn't really matter anymore, like what the catheter or wire is as much. Obviously you want to be small, you don't want to be spasming and doing things like that. But for me, I still use a 2.0 True Select and probably don't even need to use that personally, but it's just what I use and what I'm comfortable with.
All right, great to know. And then I know you said both of you use a 4 French glide cath. I think there's maybe a little bit of misconsensus, in the community about what type of glide cath to use. I just want to point out that there is a 4 French double braid, there's a 5 French single braid, and a 5 French double braid, right? And the one that I never use is a 5 French single braid. There's no torqueability whatsoever. But it sounds like both of you are using the 4 French double braid.
Yep. I use Cobra. I don't know what shape you use, Sid.
I just use a 4 French angle glide cath.
Okay, got it. All right, let's move on to topic 3. And I think as a precursor here, the three of us probably all do almost the exact same thing in practice. It's basically cancer and pain, right? Probably. And Oz, I think you're a little bit more on the pain side. Please correct me if I'm wrong. Sid, you're probably right in the middle a little bit, and I'm still a little bit more on the cancer side, specifically liver cancer. So all of us are used to doing cone beam CTs everywhere, right? So is cone beam CT helpful intraprocedurally, non-selective and or selective? Oz, you got the no. Sid, you got the yes. Sid, why don't you start?
So I think it is helpful. I would still say the majority of my practice is cancer. And so that's when I learned to do it back in residency and fellowship, and it became kind of just part of your workflow. I find doing a cone beam CT extraordinarily helpful in figuring out which arteries I want to address. Once you get used to it, just like anything else, it's an extra 3 minutes. It really helps pick out a lot of vessels that you would not normally have picked out on a non-selective, let's say, distal SFA angiogram or a popliteal artery angiogram. There are times where you're just not going to light up an artery that well. And that's in part because your popliteal artery is big. Your contrast is going to settle kind of towards the floor, right? So, anything that courses anteriorly towards the ceiling, it doesn't get as opacified, right? So that's why it doesn't opacify sometimes as much. But with the cone beam CT, you overcome those barriers. And we did a study of over 200 patients, and we found that we did a kind of this blinded review of people looking at the angiograms and then people looking at the angiograms in addition to the cone beam CT, and a bunch of more targets were chosen. And so if you go with the hypothesis that more targets is better or more appropriate targets is better, we're looking at like potentially anywhere from a 13 to 15% improvement, which is very significant in my opinion. I think it's quick, it's very easy to do, and I would advocate that everyone should start doing this for GAE.
All right. I hear you, Sid. I'll give you that. I think using cone beam or cross-sectional imaging, definitely, because it applied to me too, is, when you start out doing this, you should do it. It's a new territory in terms of anatomy, recognizing vessels, all that sort of stuff. Now, I think whether to use it routinely, I would probably say I don't think it's needed. The anatomy actually is pretty routinely recognizable. Each artery kind of has a very characteristic, shape, origin. The variants are relatively easy to recognize. So I think in the more intermediate to advanced user stage, you probably don't need to use it. And I think your data obviously is very, compelling, but still, I don't think there's any data clearly that says, well, cone beam improves outcomes per se. It does probably, obviously, may help increase recognition, but I think to use it routinely probably is overkill. That's just my opinion.
Yeah, and I would say that would be the same argument that was used for liver cancer 10 years ago, right? Every single person debating against cone beam in 2015 said, oh, once I'm used to it, I'm advanced, I know how to do, I've seen 1,000 hepatic artery angiograms. And I would argue in let's say, if you're doing a chemoembolization or radioembolization, it's pretty much standard of care, right? So I find that there are enough variants. There are times where I didn't pick up an artery or I couldn't find the angle. It actually makes you can lay out the exact angle you want. So it actually makes the catheterization faster for me. The additional 3 minutes that it takes for me to do a cone beam CT, that to me is not enough time lost to allow it to go to waste.
How about we settle on this? Whenever I'm embolizing a knee osteosarcoma, I'll use cone beam CT.
Fair enough.
Well, and I'll say it this way. I mean, to me, in the liver space, cone beam is standard of care, I would say. Whether controversial or not, it is standard of care. There's no question, right? When I do a non-selective cone beam, I can actually pick my treatment spots and go to those individual spots based off that non-selective cone beam and save a tremendous amount of time in contrast and radiation. So it's not even, that discussion is out the window at the moment. Whether we're going to get there in the MSK space, we'll see.